So I was trying to explain how you integrate response in leukemia treatment as measured by MRD with the genetics of leukemia, and how those two combine to help you stratify patients and give them the right kind of therapy. Okay, so we've known for many years that genetics of leukemia is important, that there are high-risk genetic lesions, there are good-risk genetic lesions, and people have known that for a long time. Equally, we've also known for a long time that response to treatment is a really important prognostic factor. We measure that using something called MRD, minimal residual disease. What has been, I guess, less understood or less explored is the interaction between the two, and how you take genetics and MRD and use them together to get the very best prognostic information you can. There's lots and lots of genetic lesions now. In fact, one of the talks before mine led to, I think, the conclusion that there's 23 or so primary genetic flavours of B-cell precursor ALL. But with my talk, I was at a much more simple level. You can take the high-risk genetic lesions. These are things like KMT2A, which used to be known as MLL, IAMP21, hypodiploid, lesions like that. Those are high-risk lesions. And then there's good-risk lesions, hyperdiploid leukemia, and ETV6-RUNX1. So those are your kind of classic genetic lesions. And then MRD, which is measured molecularly in the UK and in most of our collaborators in our kind of trial consortium. That's prognostic, and it's prognostic by level. So the lower the amount of MRD, the better. Thresholds of MRD are set by the test that you use and how sensitive that test is. Our data really clearly shows essentially that there is no threshold to the predictive value of MRD. The threshold is set by what you can detect using the technique. So the very best prognosis is basically patients who are undetectable with the most sensitive technique. It's really important to remember that, because if a new technique comes along which is even more sensitive, then that may change the prognosis of undetectable disease. It won't be the same thing. So that's how it works. And I guess one of the key points I'd make is there really isn't a threshold. MRD is a continuous variable. If you look at populations, there'll be patients with higher levels, middling levels, and lower levels. And the prognostic value of that changes continuously through that distribution. And that was the main point that I was making, that MRD as a continuous variable is distributed like that. But that distribution changes depending on the genetic subtype of leukemia you have. So that distribution for the good risk genetic lesions, let's take ETV6-RUNX1, so 1221, more of those patients have got lower levels of MRD, okay, compared to the higher risk lesions where the MRD levels tend to be higher, but it's not absolute. Again, there's a normal distribution of both of those groups. That's one key point. But the second point is the prognostic significance of that MRD is not the same. So if you take an MRD level, let's say 0.01%, which is a classic threshold that's been used a lot. If you're below that line, if you've got ETV6-RUNX1 disease, you're going to have an extremely good prognosis. But if you're below that line and you've got high-risk genetic lesion, that does not mean you've got a good prognosis at all. Equally, above that line, at 0.01%, if you've got a high-risk genetic lesion, you do indeed have a poor prognosis. But if you've got ETV6-RUNX1, you've still really got a very excellent prognosis until your MRD levels are much, much higher. And that's the key point that I was explaining, and this is what we're taking into our future trial, is that you need personalised MRD thresholds based on the genetic lesion. You can't use one threshold for all patients. Yes, this is going to be complex. This is complex to explain to other clinicians, and it's going to be very complex to explain to patients. We need to work out how to do that. But we already talk to patients about genetics having some significance, and we need to see what they are. And we talk to them about response, and they know about. So we don't get the response data till maybe 35 days into treatment. So the patients have got 35 days to kind of get their head around some of this stuff. So they don't need to know it and understand it all on day one of diagnosis. So we do elements of that already. It's going to get a bit more complicated, and we'll explain to them that which genetic subtype you've got affects what level we use. I don't imagine for most patients we need to explain what the exact number on the MRD threshold we've chosen to use is. They just need to get the idea that they've got certain genetic lesions and there's a threshold that they're either going to be below or not that'll affect their risk stratification. The example I gave in this talk was the new Altogether trial, which we're running across Western Europe, which will be a very large trial, recruiting ultimately hopefully over 7,000 children and young adults to it. And what I've been describing is what we're going to be using as the basis of the stratification for that trial.